Good evening, everyone, and welcome to tonight's webinar on insurance parity with Dr. Hannah Schang. Just a couple quick housekeeping things before we get started. These community education events are for MHAM members and potential members. And yes, if you didn't know it, MHAM has memberships that are very affordable for individuals and organizations. I'll drop a link in the chat for more information if you're interested. Also, if you need McBack credits, please drop your full name in the chat and state that you need a certificate. I will send you a link to complete after the webinar, and once your survey is complete, I will send you a certificate. So with us tonight is Hannah, and Hannah is a registered nurse with Henry Ford Health and a recent Michigan State Psychiatric Mental Health Nurse Practitioner graduate. She partnered with MHAM while completing her doctorate's project on insurance parity. We have a lot to dig into, so Hannah, I'm going to let you take the floor.
Well, thank you everyone for coming today. I'm very excited to talk about insurance parity today with you all. And I look forward to everyone's thoughts at the end. My project was on insurance parity. It was part of a greater research-based paper that did a policy analysis on insurance parity and what that would look like in Michigan. And here's my disclosure. I was funded by the Michigan Applied Public Policy Grant through the IPPSR at Michigan State University. And the objectives today are to define mental health parity, describe how lacking parity affects patient treatment, analyze examples of lacking parity, and identify how insurance companies can be monitored for parity compliance. So 1 in 5 people live with a mental illness, and that's 52.9 million people in the United States. That's more than those living with diabetes, chronic lung disease, which that 34 million includes asthma, COPD, emphysema, and chronic bronchitis altogether, as well as cancer. Additionally, the CDC estimates that half of all Americans will experience a mental disorder in their lifetime, so it's very prevalent. Of recent events, there's been some troubling things going on the past few years, and that's reflected in the global and national statistics. The World Health Organization found that the global prevalence of anxiety and depression increased by 25% in the first year of COVID. So the director of the World Health Organization is calling this increase a wake-up call for countries to support their population's mental health better. Nationally, between August 2020 and February 2021, 41.5 adults exhibited symptoms of anxiety and depression, and drug overdose deaths increased by 30% between 2020 and 2021. Specifically for Michigan, over a third of those with mental illness did not receive treatment in 2019, as well as only 13% of those with a substance use disorder received treatment. And while there are many reasons why someone may not receive treatment, the inability to afford the mental health care and lack of health insurance coverage were nationally surveyed to be top reasons. So what is parity? Merriam-Webster provides the general definition of parity to be the state of or condition of being equal or equivalent. Within the insurance context, which is what we'll be focusing on today, it's defined as the ability to have access to treatment for mental health and substance use disorders that's equivalent to treatment offered for medical conditions. So an example of when parity is present includes if an insurance company were to provide equally generous coverage for the treatment of depression as they would for high blood pressure. But when parity is not present, health plans are more restrictive with limitations that are applied to mental health benefits compared to medical surgical benefits. So today we're going to do a deep dive into what these limitations look like and how they affect the treatment provided. So who is affected by parity? First, anyone seeking or receiving mental health and substance use disorder treatment, as well as providers of psychiatric care. It can affect the way that they provide treatment to their patients, and knowing about parity can strengthen the mental health provider's role of advocating for their patients. So the Mental Health Parity and Addiction Equity Act is a federal law that was created to protect those seeking mental health treatment from experiencing excess barriers to accessing care. It prohibits insurance companies from placing inequitable restrictions on mental health benefits if there's not a comparable restriction placed on medical surgical benefits. It applies to self and fully insured individual and large group employment-based private health plans, so commercial insurances. And this covers 56% of Michigan's population. States are responsible for ensuring that their respective insurance companies are compliant with this federal parity law. Many have done this through enacting regulatory laws that require insurance companies to submit consistent reports showing their compliance. Michigan is unfortunately not one of these states, as we've been unsuccessful at enacting all parity bills that have been proposed thus far. So in the following slides, we'll discuss examples of ways in which insurance companies can apply more restrictive limitations on mental health and substance use disorder benefits. In other words, examples of practices that may violate the protections of the Mental Health Parity and Addiction Equity Act. I may refer to that as the MHPAEA periodically. So let's look at an example. Here we have Charisse, and she was diagnosed with diabetes, and she visited her primary care clinician 11 times in the past year for management of her diabetes. And the copay each time was $15. Her insurance provided coverage for all 11 outpatient visits. Due to the burden of the new diagnosis, Charisse develops anxiety and is seen by a psychiatric clinician. The copay each time was $30, and after her 11th outpatient visit, she receives notice from her insurance company that she has exceeded the 10-day annual limit of coverage. They inform her she'll need to pay out of pocket for the extra day and going forward. So this brings us to our first type of restriction. Charisse, these include financial limitations, their cost sharing requirements, and they include copays, coinsurance, deductibles, and out-of-pocket maximums. So in the example with Charisse, she was charged double the out-of-pocket copay amount to see her psychiatric clinician compared to her primary care clinician. This is a red flag for an insurance practice that may not be compliant with the federal Mental Health Parity and Addiction Equity Act. The second type of restriction is a quantitative treatment limitation. And this is a numerical restriction on the frequency, duration, or quantity of treatment provided. It includes day and visit limits. So for Charisse, her annual day limit for an outpatient psychiatric clinician was capped at 10 days. She would have to pay out of pocket if she wanted to continue receiving outpatient psychiatric care. Comparatively, there was no equitable cap for outpatient treatment for her physical condition, diabetes. So this represents a possible noncompliance act by her insurance company. Let's look at a second example here. We have Luis, who was diagnosed with pancreatic cancer a couple of years ago. His pain was initially being managed by tramadol, but it's gotten significantly worse in the past few months. So his clinician believes that methadone would be the most appropriate pain medication at this time, and they submit the prescription to the pharmacy, and Luis gets to start taking the methadone. We have Adrian, who has been using heroin for the past 2 years and was diagnosed with a severe opioid use disorder by her psychiatric clinician. She was being prescribed naltrexone to manage her substance use disorder, but has had multiple relapses lately. And her most recent relapse was a month ago and resulted in an accidental overdose. Adrian's psychiatric clinician decides that methadone would be a more effective treatment and submits this prescription to the pharmacy. The pharmacist notifies the provider that Adrian's insurance requires a prior authorization before coverage. After several days, the insurance plan notifies the provider that coverage for methadone will only be provided after Suboxone is trialed first and failed on. This brings us to our final restriction we'll cover today, which is a non-quantitative treatment limitation, also called NQTL. And these are non-numerical restrictions on benefits. They include any process, strategy, evidentiary standard, or the criteria that limits the scope or the duration of benefits provided. They commonly manifest as prior authorizations, medical necessity reviews, and fail first, or also called step therapy policies. So let's go back to those examples. So Luis was able to obtain his methadone, which was prescribed for pain on the basis of physical illness. The insurance company did not require a prior authorization for prescription or require him to trial or fail first on an insurance preferred medication before covering the methadone. Meanwhile, for Adrian, who requires the same medication, but on the basis of a substance use disorder, the insurance company required the clinician to submit a prior authorization and still deny coverage for it until an insurance preferred medication was trialed or failed on first. Also notice the delay of treatment Adrian experienced due to the prior authorization requirement, and not to mention the extra time and paperwork that it required the clinician to submit the prior authorization, as well as any other communications that would be required between the insurance company. In this way, lacking parity can negatively affect psychiatric providers disproportionately if this type of paperwork is occurring more frequently for psychiatric providers. This can contribute to higher rates of burnout and turnover. So let's continue our review of possible parity violations. And these, the ones that will follow, are from submissions from the Parity Track Consumer Complaint Line. And Parity Track is an organization that tracks legislative, regulatory, and legal parity activities in all 50 states, as well as federal. They're also an excellent source for anyone looking to learn more about parity, as well as for those who believe they've been wrongfully denied coverage. So here we have a daughter of a woman, and she was having some pretty serious thoughts of self-harm and taking her own life. And while seeking treatment, the insurance company required repeated reviews for medical necessity of her psychiatric treatment. And she was ultimately denied access to treatment when in a dangerous condition. So in this case, the red flag for a possible Mental Health and Parity Addiction Equity Act violation is the frequent medical necessity reviews. If the insurance company cannot prove that they don't have a comparable medical surgical restriction, this could be a parity violation. Couple more examples here. Under prescription cost, we have a situation where a mental health medicine was minimally covered. And if the insurance company does not have a comparable medical surgical medication that is also minimally covered, this could represent a parity violation. For our third example, we have another example of step therapy or fail first. And the main point here is that the person was faced with a pretty distressing situation. They had to pick between tolerating a bad medication, or a medication where they know they've had a bad reaction to, pay out of pocket for the new medication, or not access treatment at all. And again, if the insurance company does not have a process that is comparable for a medical surgical medicine, this could represent a violation of the federal parity law and a violation to the patient's right to access equitable mental health treatment. Bottom line, when insurance companies do not have a comparable medical surgical limitation, they are not following the federal parity law. In this case, parity is not present, and these limitations can restrict coverage of mental health care more than for physical. This can lead to denials to coverage or delays in care that are disproportionately placed on mental health benefits and represent excess barriers to accessing cares. So the red flags that we've been reviewing are just that, signs of possible noncompliance. A deeper analysis would have to be done to know precisely if there is a comparable restriction for medical surgical services, and if not, which mental health benefit is being restricted and to what extent. So the Mental Health Parity and Addiction Equity Act is important because as we've seen, it can protect more visits for patients, which means more care is being provided. If mental health care is lower cost, then that means that there's less barriers to accessing care. Fewer delays in care means better patient outcomes, and less inequity means less stigma is being perpetuated. So these figures were taken from the 2016 and 2018 reports to Congress, and those are biannual parity compliance reports that are created by the United States Department of Labor, Department of Health and Human Services, as well as the Department of Treasury, referred to as the departments. So as you may see here, they found that the non-quantitative treatment limitations represented a large majority of federal mental health parity violations. The federal government has recently strengthened their compliance efforts to better target these non-quantitative treatment limitations through conducting comparative analyses. So comparative analysis is a type of reporting requirement which requests information from health insurers that would determine their compliance with the Mental Health Parity and Addiction Equity Act, particularly those non-quantitative treatment limitations, because due to their non-numerical nature, it makes the process of determining compliance less transparent. This brings us to the Consolidated Appropriations Act of 2021. And this is a federal law that amended the MHPAEA and provided new protections. It represents a tool for enforcement of the MHPAEA. And through this federal law, the departments are required to assess 20 health plans each year for MHPAEA compliance. And please note that those picked are typically due to the volume of consumer complaints received through insurance departments. And so the Consolidated Appropriations Act was passed due to the need for enhanced federal support to improve parity implementation from the states. And this became evident through the reports to Congress, particularly the 2022 report to Congress, in which the depth of noncompliance was revealed, as not a single one of the non-quantitative treatment limitations assessed from all 20 health plans could prove compliance with the federal parity law. And thinking about the 1,096 health plans that are registered across the country, the chances of a single Michigan-based health plan to be evaluated is pretty low. Clearly, more support is needed from the state level if we hope to gain more clarity into the state of parity compliance in Michigan. So in the following slides, we're going to review exactly what goes into determining compliance through a comparative analysis. A comparative analysis looks into these 4 steps. First, they identify the non-quantitative treatment limitation. So as a reminder, those can be prior authorizations, medical necessities, or step therapy, or fail first policies. Secondly, they identify the factors that are considered in the design of the NQTL. In other words, what reason led the insurance company to believe a restriction was needed? It could be they've seen an excessive utilization of a certain benefit, recent cost escalation of a certain treatment, or what they found to be a lack of clinical efficacy. The step 3 is to identify the sources used to define the factors involved in designing the NQTL. In other words, what sources were used to support the reason for application? It could be the evidentiary standards that they used, medical expert reviews, or internal claim analysis. And were these sources comparable between mental health and medical surgical benefits? Was there any variation in application of a guideline or a standard between mental health and medical surgical benefits? And the 4th step is to ask the question, are these processes, strategies, and evidentiary standards used in applying the NQTL comparable and no more restrictively applied? Insurance companies have to demonstrate the methods, analyses, or other evidence used to develop and apply the NQTL. If inequity or simply the lack of rationale exists, it's considered a violation of the federal MHPAEA. So let's apply this knowledge to Adrienne here. So as a reminder, she was denied coverage for methadone, and they required that she be trialed on Suboxone first. So how would we use a comparative analysis to determine the compliance of the insurance company's actions here? First, we identify the NQTL, which is the fail first and step therapy protocol. Step 2 is to identify the factors considered in the design. And since these protocols are often used as cost-saving measures, let's say the insurance company considered methadone to be a high-cost intervention as a factor in applying the non-quantitative treatment limitation. Step 3 is identify the sources that were used. So let's say that the insurance company used analysis of their claims to track costs associated when methadone was prescribed for a substance use disorder patient. They state that this was used when considering it high cost, but they did not have a written policy for what high cost meant. They didn't have any definition, any number to signify what high cost really meant. They also could not provide documents that compared costs associated with methadone being prescribed for a medical surgical reason. So here comes the question. Was the process, strategy, and evidentiary standard used in applying the NQTL comparable and no more restrictively applied to this fail first protocol? Since the insurance company could not provide the necessary evidence that could prove the methadone was not being restricted inequitably, this looks like it represents a parity violation. So how does this relate to Michigan? As stated before, all of Michigan's efforts have not been fruitful. So as you can see, we have 5 total bills that are in the gray font. The first 4 are all failed to advance past the respective committees. So a couple of them died in the insurance committee and a couple of them died in the health policy committee. I want to bring particular attention to House Bills 6137 through 39. Those were good bills, as they included annual compliance reports to be submitted by the insurance companies. And these compliance evaluations would have had a particularly positive impact on ensuring parity compliance in Michigan. I also want to bring attention to Senate Bill 27. And this is a parity bill in the current 2023 legislative session. Unfortunately, it does not include any reporting requirements. And without those, there'll be less accountability for our insurance department to conduct compliance evaluations, as well as less accountability for the insurance companies to practice parity. And just to show a refresher on the legislative process here in Michigan, and just a reflection of where all of the Michigan parity bill packages have failed so far, pretty early in the process. So here we have 6 states, and all of them have 3 things in common. You may be thinking about one of them in your head. Yes, they all have state parity laws that grant their insurance departments the authority to monitor and enforce the MHPAEA. And these are in the form of required annual compliance reports from health plans. Secondly, all have been successful at holding their health plans accountable for following the federal parity law through enforcement. And third, all were evaluated by the Substance Abuse and Mental Health Services Administration for common best practices for parity implementation. And those best practices helped streamline the process of implementing their state and federal parity laws. So as you can see here, we have those 6 states at the top. We have their respective insurance plans, and then we have the enforcement actions. And these are actions that were able to be taken due to these state parity laws that require a deeper analysis into the insurance practices. All of the corrective actions that are stated here were due to violations of parity laws that were the same examples as we covered today. And several of these states submitted follow-up reports showing that the inequities had been righted. And this stands as evidence that state parity laws require consistent compliance reports do make a difference in ensuring the implementation of parity laws. I also want to point out a particularly successful example under New York, and the second bullet point there, the $3 million in fines. And $2 million of those were out-of-pocket costs that were then reimbursed for previously denied claims across 300 consumers. So these reporting requirements can really have a large tangible impact. So what can be done? We need to enact a parity bill that will require these annual reporting requirements by insurance companies so we can have greater clarity into their compliance. And we need to show support by contacting our legislators in spreading the word about the importance of parity. We can enact a parity bill by either requesting a change to be made to the current parity bill, SB 27, that includes monitoring requirements, or discuss with parity supportive legislators to sponsor a new bill. And if a new bill were to be sponsored, I would encourage policymakers to model it after the American Psychiatric Association or the Kennedy Forum model parity legislation. And the current senators that are showing support for parity are Senators Anthony, Wojno, Geis, Kavanaugh, Singh, and Schang. So if you do feel obligated to do some reaching out, I would encourage you to reach out to these legislators. Third, psychiatric providers like clinicians, social workers, nurses, we're on the front lines of observing possible noncompliance. So watching for red flags of parity noncompliance in practice is an opportunity to advocate for our patients, as well as empower them with information that would help them receive treatment that they're entitled to. So if you feel that you or someone you know has been wrongfully denied coverage, the first step is to appeal the denied claim internally through the insurance company. They're required by law to provide you all the documents used for the claim denial in detail and upon request. And remember that under the Federal Consolidated Appropriations Act, most health plans that become flagged for comparative analyses by the federal government are the ones with the most consumer complaints. So it can be productive to submit a complaint to the Michigan Department of Insurance when you feel that there's been a possible non-compliance action. The more complaints they receive about parity issues, the more that they're warranted to do a wider investigation. Finally, if you're not satisfied with the amount of information that the insurance company gave you and you are still concerned, you can externally appeal the denial through the Department of Insurance here in Michigan. And I just wanted to show how the process of appealing a denial goes. This is taken directly from a document on the Michigan Department of Insurance website. And this document contains really good information on how to appeal a denial and also submit a complaint. So if you are interested in doing that, here is a little guide on how to navigate to that document. And just as another resource here, through Parity Track, they have a lot of good information on parity specific information as it relates to appealing a denial. So in conclusion, mental illness is a very prevalent issue in our country, and it's critical that requires more intervention. Insurance parity is the ability to access treatment that is equivalent to treatment offered for medical conditions. And when insurance practices apply more restrictive limitations to mental health benefits, that's against the federal law. Disparity has negative effects on patient treatment, and those states that have monitoring and enforcement laws have been successful at ensuring parity. Finally, we can all take action to impact Michigan enacting a similar legislation. And I have some references here, and I would love to take any questions or thoughts that people have.
So I have a question, Dr. Schang. If so the reporting compliance that's done by these other states, is that annual reporting? So that is kind of a pain. And then someone has to be reviewing those reports, and they don't always follow through, as my experience with Michigan. So if they, in fact, said, we are going to use the Kennedy Forum model or the other model that you mentioned, and if they do not have, let's say, below a certain number of complaints, that they would get a free pass on reporting, which would be a bit, kind of, it's a burden lifted that shows probably, that they are complying because they have adopted an acceptable model and they aren't getting complaints. So is that something we might consider advocating to the Senate to do Or wouldn't that really work well with the current Senate Bill 27?
Yeah, so could you just kind of restate your question? What is it exactly that
So-
you are hoping to advocate?
Would it make sense to ask the insurance companies, so rather than ask them to report their compliance annually, which could be
Okay.
fairly extensive reporting, and then someone at the state has to review it, right? Instead of having to do that, if they adopted one of the acceptable models like the Kennedy
Mhm.
form, and if they had, a certain, a very low number of complaints, then they would be exempt. They would get an automatic exemption from having to do.
Yeah, I think I got most of your question. So a couple comments. First is that not every single state chose to do annually. Some did biannually. So maybe that's something that's more realistic. Secondly, through the Consolidated Appropriations Act, they require that insurance companies make these compliance reports available each year. So whether Michigan has enacted a law that would require them to have annual compliance reports submitted, they're really expected and federally required to have these compliance reports ready in case of auditing each year. So a state law that requires it is asking no more than what the Federal Consolidated Appropriations Act asks for. It's essentially just asking that insurance companies make these reports available to the insurance department each year. And then to your question or comment on, I definitely think it's an interesting idea, the idea of exempting them if there's a certain level of low enough complaints that possibly that insurance company could be exempt from submitting the analysis. I think that, it was surveyed that only 4% of Americans know about parity. So my concern with that is that not enough people know about parity to even know to report it. So there could be, I think that provides the opportunity for a lot of missed, evaluations and possible circumstances where noncompliance could be happening when people are missing out on benefits, when the risk is so high of people missing out on benefits. I think that the insurance companies really need to be monitored closer, especially when the level of noncompliance was shown to be so high with those reports to Congress. Does that kind of answer your question?
Mhm. Yes,
Yeah.
thanks.
Sure. Thank you for your question. Looking through the
All right,
chat.
I didn't know if somebody was going to call on me or not. You just kind of answered one of the questions, which was, how does the average person know whether or not there's no parity in comparison? How would you figure that out?
Right. Yeah, I think that is part of the public education, that, partnering organizations like MHAM, NAMI, the APA, American Psychiatric Association. A big role of these organizations, as well as it should be the insurance department's role in educating consumers. Unfortunately, our insurance department has not really taken initiative to do that. But I think a big part of that is we need to be educating the public more. People need to know more about their rights to be receiving equitable mental health care. I think in general too, there's always something that you feel is wrong when you hear about someone getting denied basic psychiatric care. Something in your head kind of goes off, that doesn't seem right. But if there is any concern at all for a possible parity compliance concern, I would recommend you to just appeal the denial, and submit a complaint. And if nothing else, they can look into it and they're all good. But if they are, but if it is found that they were out of compliance, then I would say, it's absolutely worth any amount of time that it would take, because it not only helps you or whoever get the mental health care that they need, but it also raises a red flag to the insurance department in the federal government that there's some issues happening here that need to be looked into.
Okay, well, thank you. But I'll just make one more comment that the insurance lobby in Michigan is very, very powerful.
Okay.
So that's why it's not going to pass like the insurance committee. And I saw that, I'm like, no, it's never going to pass that committee. So that's a huge hurdle.
Yeah, it's certain, and thanks for saying that. It certainly is going to require a lot of countering support to that, coming from the public. I think the more the public knows about it, the more people will realize this is not right, and more public support is really important, as well as getting more organizations on board to support parity efforts. Marianne, do you have your hand up?
I do. I just wanted to make a comment to Christine's comment. So last year, when we had 3 bills regarding the enforcement of this provision, last year we worked on those bills with the Michigan Psychiatric Society and the American Psychiatric Association. And we deliberately chose requiring the insurers to turn in those reports that we know they're already required to do them, but they're not necessarily required to turn them in to the Department of, Insurance and Financial Services. And we wanted them to do that as a first step. And we know the power of the insurance lobby, particularly the big one. So we wanted to start there and see where we got. I will tell you that you'll be hearing about another bill that's not coming from MHAM. It's coming from a national organization called Inseparable. MHAM is part of that. It's going to be focusing on parity, but also medical necessity criteria as well. So be on the lookout for that. But anyway, we recognize that it's going to be a bit of an uphill battle to do this.
Thank you, Marianne. As far as Medicare goes, it does not specifically apply to Medicare as of right now, but the thing is, so the difference is with mental health, with the MHPAEA, it doesn't require that insurance companies required to cover mental health benefits, whereas with Obamacare, they made the requirement of covering mental health benefits. So there is no specific, parity requirements for Medicare as far as I'm concerned. Good question.
So Medicare recipients are stuck then, right? I called Priority Health Medicare, who I have, just to see what kind of benefits they have for mental health services, just out of curiosity. And, they had some decent benefits for inpatient, but they had nothing for crisis residential stays. And I don't know if it's because they don't yet know much about crisis residential care, or they know about it and just aren't doing anything about it. So what is it going to take then to get, there's a lot of people on Medicare. What's it going to take to get parity there?
As far as that goes, I wonder if Marianne will know more about that, but because mostly my research focused on commercial. Marianne, do you have any thoughts on that?
Yeah, in order to amend that, that's going to have to go through, that's going to have to be at the federal level. That's going to have to go through Congress. I can check with Mental Health America, which is our parent organization. They're always working on issues relative to Medicare. So I can find out if they're working on anything at the federal level. I would imagine they must be, because one of the other problems we have with we have with Medicare is not only does it not provide a full continuum of care, although I would let you know that most private insurers do not cover crisis residential care either.
Right.
I think the issue too is that for mental health, people with mental illness who have Medicare, they have a limited number of inpatient days. They have a lifetime allotment of inpatient psychiatric days. And when those are gone, they're gone. Then they end up having to have Medicaid as the payer. So another parity issue. But what I can do, Kate, is I can follow up with Mental Health America and see where they are. I'm sure they've got to be working on this issue.
Okay, thanks.
I have a quick question, if you can hear me okay.
Yep.
So I guess the world that we live in is pretty split and pretty partisan. How would you, I guess, convince someone that is maybe more liberal leaning that parity is important versus how would you convince someone who's more conservative that this is a very important issue for everybody?
It's a really good question. I believe that parity is a nonpartisan issue here. And that is because, first of all, if 50% of Americans would be affected by a mental disorder, that crosses any kind of party lines. But I think that, appealing to just how prevalent it is, and, mental health is health. And I think that although like my research had found that more liberal, leaning legislators more of those were likely to support parity over conservative. That just kind of shows that, where any efforts to try and gather, provide more education and gather more support to these more conservative legislators. I think that that is an angle I would take, as well as, just with the increased prevalence of mental illness after COVID, as well as the shootings that have been occurring and affecting everyone. I think that, mental health is a big issue right now. And while there's other bills that more directly approach or more tangibly approach solutions towards mental illness and shootings, I do think that, putting more effort towards parity would overall help anyone. And so to me, it's not really a partisan issue, but I think that I would just try and target with education, because a lot of times people don't know the details of parity and they may have misconceptions. So that's probably the angle I would take.
Yeah, the importance of the downstream effects that this could have could be a really good angle. So yeah, thanks.
Yeah, exactly. And it has such a wide effect range. I mean, it would affect almost everyone, half of everyone. So
Hannah, can I add something to that? What I want to add, and this is just really my experience in doing this legislative work. Usually it's the legislators that have had firsthand personal experience with a loved one or their own mental health condition or the mental health condition of a child that really end up carrying the water on these issues. I've seen it over and over again. For example, former State Rep Mary Whiteford had family members with mental health conditions, which is why, she was very much into furthering, mental health. And she was one of the co-sponsors of the parity bills. So part of it is, and this is, of course, mental health issues affect Republicans and Democrats. I think one of the things that I know that I look for is finding legislators who have a personal interest in mental health and then looking at ways to kind of help them become mental health champions or educating them on these issues. Because to Hannah's point, a lot of people do not understand. I mean, the parity law is very complicated anyway, but a lot of people have no idea that we don't have parity. For example, state of Michigan employees don't even have mental health parity.
Michelle, so your question was, how does collaboration occur nationally with other organizations on parity laws, such as NAMI with local chapters? What specifically about collaboration are you referring to?
Yes, sorry, I was just trying to figure out, as far as collaboration, like conventions or any type of work, relating to, support of a certain bill. Is there any, collaborations with other associations, and mental health associations that would, help strengthen the voice, for parity laws?
Yeah, as far as like, you're curious about what other, sorry, Amazon's going on. We'll just let her talk. So you're wondering like what other organizations would come together to essentially support parity being enacted in Michigan?
Correct, yes.
Okay. Yeah, so local chapters, like you said, NAMI, MHAM here, the American Psychiatric Association. Let's see what other ones. Oftentimes, the American Psychiatric Nurse Association. I know there's a Social Workers Association. Not all organizations are interested in policy work, but some of them are. Marianne, are there any off the top of your head that you would want to? So yeah, Marianne.
Yeah, so I put him in the chat, and there would be like Disability Rights Michigan, which is the protection and advocacy. They've expressed an interest. The National Association of Social Workers, the Association for Children's Mental Health, and of course, Michigan has a NAMI chapter. But Michelle, to your question about at the national level, there's national organizations like Mental Health America, which is our parent organization, formerly known as the Mental Health Association, the National Alliance on Mental Illness at the national level. So the national organizations will frequently get together and address these policy issues. And of course, they do a lot of lobbying at the federal level as well on these issues. So yes, they all do come together to address the bigger picture policy issues at the national level.
There's also the Kennedy Forum is a large organization that is devoted to parity efforts at the state and federal level. And they have done, specific projects in certain states, like Illinois is an example, where they helped that state enact a parity law. So the Kennedy Forum is a really good organization for that too.
Well, Dr. Schang, thank you for being with us tonight and imparting your wisdom upon us. We appreciate you being
thank you
here.
so much for having me, and thank you to everyone that came and asked questions. Go forth and let's make mental health benefits equal.